So guys, we'll go ahead and get started. We know a few others will be trickling in before we hand it over to Chairman Dr. Dainty Pierce. It's like the right Reverend Doctor. Again, want to continue to share our appreciation to each of you and what you guys are doing. It's tireless work, but it's meaningful, and ultimately will lead our city and our region and ultimately our state to a brighter future. So thank you so much. Just a few brief updates of what's transpired since we've last seen each other. The city of Little Rock has issued a curfew to help flatten the curve from midnight to 5 a.m. Until further notice. However, we will be reassessing every 2 weeks in an effort to help flatten the curve. And the question is, why that period of time? Number one, it helps to discourage large gatherings at bars, clubs, things of that nature. As you know, that's an easy way to transmit the community transmission of it one of the ways, and so that's one of our efforts to kind of help flatten that curve as a reason why. Secondly, the city of Little Rock facilities start, and that will begin on Wednesday until further notice. However, we will be checking every 2 weeks. Secondly, all City of Little Rock facilities will cease public access. So we are encouraging all of our patrons, residents, vendors to utilize our online platforms to continue and carry on with the City of Little Rock business. City of Little Rock is not closed, but we'll be ceasing public access and redirecting the public to our online platforms. And that's all City of Little Rock facilities owned and buildings. Thirdly, Steph, am I missing something? Access, curfew. Our next board meeting will not be here. We're going to practice social distancing as well at the Robinson Center as we move forward and reassess. So I think those are really the three things that have transpired in that last meeting. From what we walked away from our last meeting was one, Doctors Novak, DeLapp, and Dr. Mehta. We're all going to work on a one-pager for pre-screening for all pre-screening, as well as the Southwest Little Rock Hospital and future and forthcoming North Metro hospitals. So I know that's one thing. Secondly, Greg Crane with Baptist Health is supposed to be reporting back to us on the inventory list to get to myself and others as we're working with Region 6 of HHS and other federal officials, in addition to what may or may not need to be done to the Southwest Little Rock Hospital from an operations and a construction standpoint. Thirdly, we had already shared that Dr. Patel was going to be working on the training for our EMT workforce. And then fourthly, John Swanson was going to be giving us a report on the EMT workforce based on his perspective. As we move forward, we understand that all of our drive-thrus right now are at UAMS, Baptist, as well as St. Vincent's and Arkansas Children's Hospital. We're going to do our best to divert as much of that to the Southwest Hospital, and then each of the chief medical officers or chief leaders that are representing our healthcare sectors were supposed to visit with their chief executive officers for two things. One, to help with capacity at the Southwest Hospital as well as the North Metro Hospital, so to identify personnel that can do there. Secondly, we discussed the notion of moving towards for the time being, discontinuing elective surgeries. I think that's a good recap. Chairman?
Okay, let's get to work. John, where do we stand?
With respect to EMTs, reached out to the health department. There's about 2,000 EMTs with that, and that title includes paramedics, the entire scale of people who are registered with the health department, who are considered non-affiliated. Those folks, some are volunteer firefighters, but most of them would be people who are inactive but have done what's necessary to maintain their licensure, meaning on a 2-year cycle, everybody has to go through refresher training, if you will. So there's about 2,000 of them. The the health department has addresses and contact information for all of them, but if there was a need for those, the recommendation was that we would approach through Adam and make a need known, and then Adam through the health department would initiate the process of organizing what might be volunteers. The question to be answered is, what is their affiliation with the agencies they're going to work with? Do they need to be employed? Because there's really no structure right now for a formal volunteer as far as licensure, liability, training standards, and so forth for them as independent EMTs.
John and I actually talked earlier. Let me just, so we don't all spend a lot of time. Here's the problem, Mark. Glad you're here. This is a ready group of people, but y'all got to contact them. We can't contact them. What I've suggested to John is y'all officially contact them, and we get the list of their names, and we'll send them a letter. We generate a letter saying, this is a problem. Are you available to help? Whether you're in screening positions or whatever you do, are you available to help? The big problem for you is that if we ask them to help, there has to be some way that we can assure them that if there's a liability, that if they get sick or something happens, that we're covering any liability. So I don't know how we do that, but I can't in good conscience send a letter out from this group saying that we want you to come help, and then if you get sick, say, we really appreciate you being here, but you're on your own now. So that's a problem we have to address real quickly.
Sure, and you all are so fortunate to have a group of attorneys here that represent the city of Little Rock that can assist you with those questions. Rick Hogan was one of my predecessors, and he helped write the public health law bench book, and we use that and rely on that now. He is a very good resource. Also, the health department is making sure that all of the rules for licensure are being relaxed pursuant to the governor's emergency declaration from last Wednesday. Also, the national emergency declaration is assisted with 1135 waivers and HIPAA and EMTALA and all of the relaxation of the rules. So under the emergency declarations, we have a lot more leeway as far as dealing with our licensure issues for all of the health professionals.
The liability issue is what I want to make sure we start with.
Right, and the providers should be talking with their attorneys, and the city of Little Rock can use their attorneys to help draft any letters that you all come up with. I'm happy to assist with that.
So who do we get running up with that?
We're gonna get Alex Benton, our attorney's office, to work with me.
So you two will work together. You two, so, sorry.
I may be representing them today.
Well, we need to get him to send out an official letter, and then if John, if you can work with them to get a letter from this group saying, we need your help. We'll work on the liability, we'll work on how to cover you for this time, but let's get that list out to those people and get a list of people who are willing, especially if they're in central Arkansas, that will help. Speak into that.
Dean, I'll add, if you will, allow me, that as everyone at the health side knows, the state is divided into 7 regions, and this is the metro region, so the health department can help us focus on those EMTs that are in the central Arkansas area. That number will be less than, well, under the 2,000.
But if y'all, if 3 of y'all get together with our attorney right after this meeting, can you call him?
We got it. We got it.
Stephanie get down.
Yeah, I'm getting ready. Okay.
Yes, sir.
Because I mean, we've got to get those people, because I think there's going to be some ways that we can help staff the Southwest Clinic and other clinics coming up. But that would be a very easy way, because they understand what to do, but we got to get that out there. Where do we stand on the clinic, on the machine, Southwest?
I think think we can have something up and running in 2 days in terms of testing.
In terms of screening,
We got to talk about how we're doing this in terms of swab testing for flu and for RSV and for strep. And then escalate that up to the different labs based on if they fail those tests is what we're talking about. Impression that they're on site, we will be able to do some basic screening tests, those three, strep, flu, RSV, and if they failed those tests, then elevate that up to a hospital lab or to another lab that can do more advanced testing.
we can perform the collection for the COVID-19 test at this site at Southwest, and then, but the actual machine that runs the test isn't there. The sample would have to be sent somewhere else.
You think we can do COVID-19 testing there?
I can stick the thing in their nose that I can then later test off of.
Right, but that's what I'm saying is.
Yes.
So, right, but this is one of those things for Frank. Do we have enough swabs?
No.
Yeah, that's number,
Just put that on the list.
you asked me, that's number one on my list right here.
So we don't have to go through the list, just give me the list.
Yep,
Okay,
yes, sir, I got it
but
right here.
swabs are the number one thing. I sent 2 people in today, and they both come back saying, we'd like to do the test, but we don't have any swabs. So, I mean, if we don't have swabs, this whole thing is moot. So-
Swabs in the media, the test media to transport the swabs, so
Right.
you gotta have both.
So there is zero reason to open till we have those. I mean,
I think we sent out guidance yesterday to all hospitals and providers about media, alternate ways to use. I think including just normal saline that can be used for shipping stuff, so, we don't have to worry about media if it's not available. We can ship it in simple normal saline apparatus.
Susan, how many swabs do we need to open that clinic up there? I mean, I don't want to open something and tell people to come if we don't have what we're gonna ask them to do. If we can't tell them they've got 3 things that we know we can test for, and we can't get a swab for COVID, there's no reason to tell people to drive that far, to stand in line and say, you really may have something, but come back tomorrow.
Today, we don't need that many, but, March 30th, you may need 2,000 in a day. I mean,
Yeah, that's how pandemics
I know,
work.
but I'm just trying to help Frank know how many we're asking for.
So I can
Well,
tell you, I
I mean-
checked just.
Hey guys, just give Craig the list and we'll move forward.
Okay, I checked before I came, our drive-through in the last 3 hours has run 23 samples. So that's 7 an hour at the beginning of the curve. And the curve, remember, will be exponential. So, I mean, we could find out between our 4 drive-throughs what the numbers are. And then I think you multiply those by 2, and then that number by itself, I mean, it's just exponential.
But it's in the hundreds we have to have.
Yes.
Okay. How many of y'all have?
We have not advertised, so we're in the single digits right now, to be honest with you.
Thousands. We just doubled our testing from yesterday to today. It's going to continue to do that, so.
I imagine once we advertise it.
So when we know we have the swabs, Greg says we can open, then we're gonna open, but not till we have that, and then we'll figure out staffing. Okay? Is that, I don't wanna send people out there and give them false expectations that we can test for strep and influenza right now. Correct? Probably, in the next day or 2.
Yeah, I think there's hospitals starting to run out of those, so I think that's a conversation for.
Well, but again, what Frank needs is a list of how many we
Yes.
need and what
Yep,
we
I
need.
got that right here from him.
Okay. Even you wanna talk about deferring surgeries?
We had executives from 7 institutions meet by phone this morning, including Baptist Health, Arkansas Children's, St. Vincent's, Arkansas Surgical Hospital, Arkansas Heart Hospital, CARTI, and UAMS. And there's the consensus that we need to be mindful of delaying potentially elective surgeries, elective procedures, but there's a great deal of sensitivity around making sure that each organization have the responsibility for prioritizing time-sensitive care. So I think there is agreement that we need to do so, one, to protect patients who can have their procedure performed at a later date, and protect our supplies while not going overboard with respect to an edict that is best judged by each single organization and the providers there. So I think we'll be able to put out a statement later on from those 7 organizations that will cover this. I know that for some of those organizations, like UMS, we already announced that we're going to reschedule those elective cases that can be rescheduled starting tomorrow. And I think there are others that are ready to do so. There was some discussion around the ability for our organizations to benefit from the government, the federal stimulus monies, if we voluntarily curtailed procedures. And I think that's a nuance that I hadn't considered until it was brought up. And that's being reviewed by our federal legislative delegation right now, and it's supposed to get back to us.
Well, I talked to Frank Gill, he's looking into it right now for us. I got him on the phone when y'all called me today. So he's looking at how I appreciate the caution, but we have to be in a position, as our infectious disease people have told us, once we see a curve going up, it's too late to start. I mean, I'd rather act too soon and be criticized than too late and say, oh my God, what have we done and what have we not done? So, Bruce is gonna look into it and we'll figure this out, but I'd like to get this figured out this week on what to do. If that's okay with all.
We're there.
Okay.
We just have to figure out the wording of the...
Friday's the deadline, we're gonna make a decision. Is that okay with
That's a
everybody?
crazy late deadline, just so everyone knows.
What?
4 days from now, during a pandemic, this has a 33% rate around the world, and everywhere that there's been an outbreak, the numbers go up by 33% a day. So on Friday, it's going to be a very, very different situation than we're dealing with right now.
I agree with you. And the unfortunate thing about being down here sometimes is the reality and politics get mixed up, and we're gonna get this done as fast as we can. If we get it done before Friday, as I said, Stephen called me and I had French on the phone in an hour and he's working on it right now. So if we get something done faster, we'll get back.
Yeah, so I agree with Amanda. I think there's a public health issue here, and there's the reality of finances. But I don't think anybody around the table disagrees with the need from a public health perspective to make sure that we don't interfere with providing timely care for those that need care right away. I think it's the degrees of what constitutes elective care that needs to be evaluated by each organization and physicians with their patients. I can tell you what UMS's decision is, but I can't say what that is for other organizations.
And just to say that it can be done, Kurt Hagedorn left the meeting Sunday and went and canceled all the elective surgeries at the VA.
So we reviewed each one.
Yeah,
And there were some that really.
well, you found the ones that needed to be done, but the ones that were just, so we're in this, we gotta get it done as soon as we can, but we're gonna get it done as soon as we can.
And the language is unfortunate because elective, when you post a case in the OR, elective means not emergency. We don't have to take it now, but that doesn't mean we're just doing it for fun. I mean, some surgeries are elective but absolutely necessary. A cancer that's growing in someone's belly needs to be addressed we schedule that, you know, we don't do it in the middle of the night, but so that's elective, but not actually, it's not unnecessary.
I was gonna ask, is there such a term as non-essential elective surgery?
I think that we have to differentiate between elective surgery, urgent surgery, and emergent surgery. And really, no one's gonna question a surgeon that says, this is an emergency, I need to do it now, we're gonna do it.
Yeah, I think that's how we're looking at it, as the time-sensitive nature of it.
Exactly
So
right.
there's
And
elective,
so it is the
time-sensitive,
time
elective, not
sensitivity,
time-sensitive.
right?
What time frame are you talking about? Is this 4 weeks or is this 6
No,
weeks?
one of the things that we've talked about, one of the things that we've talked about, and I don't know if this is the right answer or not, but it's a jumping off point, is that if a patient's quality or quantity of life would be significantly impacted by delaying the surgery for more than 2 weeks, that becomes urgent. So throw that out there as a starting definition for what urgent is. And then the other thing that we've talked about is that each hospital, each institution should have their own multidisciplinary, or however you choose to do it, needs to have a review process as cases are scheduled. And what the escalation of that is if there's a disagreement. And somebody has to be the final say on that. We've got to be prepared to step up and do that, to see which one of those blocks it fits into and whether or not it's appropriate to proceed given the environment that we currently live in.
I like the language of non-essential better than elective, because elective really does have this specific thing that in medicine doesn't mean what you think it means. But non-essential, I think, in lay terms, is a better description of what we're talking about.
So again, Dean, I think every executive around the table agreed to doing that assessment for their organization. Some are a little bit farther ahead than others, but by the end of the week, every organization at the table will have established
So is that a deal by everybody? 1, 2, 3, 4, 5, 6, 7, okay. I mean, because Friday, we're gonna put out the word of what we're doing. Start it now if you can. Kurt is a perfect example of it. I mean, he spent all Sunday afternoon saying, this procedure needs to be done or this could be put off. So we need to start doing the same thing. And it's a hard thing to do. I mean, I've already had 2 calls from 2 surgeons, one at St. Vincent and one at Baptist, saying, what are y'all doing to me? That's fine. I mean, that, you know, it comes with the territory. But, you know, the problem with doctors is that every doctor thinks that the other doctor's isn't essential and mine is. And you know, that's just, it's the nature of the beast that we all do. Because that's our job to take care of our patients. But this is not that situation, and that's not the way we're going to do it. So,
go ahead. The other thing that we've got to discuss is this, not just limited to, at least from a point of discussion, not just limited to surgeries, but limited to outpatient procedures, screening mammograms, screening CT scans of the chest, things that we've talked about. This has to be, back to your term, all non-essential visits to a healthcare facility.
Bone density scans.
Bone density scans,
Yeah.
absolutely.
We're,
Is it non-essential surgeries and procedures?
yes, and I just to be truth in advertising, I've got a surgery center that I do colonoscopies in. By the end of the week, we're gonna be through.
I would just expand that even to patient visits.
Yes.
Yeah, we are.
I mean, that's just, but I'm just suggesting all of that,
I think
because that's just
all of those
population on
things have to be
campus.
done, but we're gonna stop doing it because here's the problem. In my business, our society has put out the things that I need to have on me and on the patients to do successful procedures. In order to do that, that's the same supply line that you're taking and I'm taking are the things that I need to protect my patients and myself, but it's not essential. So we're just gonna shut down. We're just gonna shut down. Now, I've not talked to the other gastroenterologists in town yet, but I'm gonna talk to them. And Kurt's right, bone densities, any sort of test that brings people in contact with other people that you can put off for 2 or 3 months is tests that we need to do. So we need to talk to radiology associates and radiology consultants and say, look through your list, and if it's there, quit it, don't do it.
I just would urge, let's not use non-essential, because that is in the eyes of the beholder, and this is really a time frame argument, not making a judgment about whether something's essential or not. So, to me, the better approach is looking at, making a judgment on how long we have to be, we're gonna predict that the pandemic is here,
I'll just
and
say
have it,
right now, that time gets longer and longer the longer we delay.
I agree with that. So,
So
this has,
President Trump just said he wants to discontinue the number of folks that are eating around 10. That 4-day wait time we're talking about, they need to be shut. So whoever needs to talk to your people, talk to your people.
Stephanie, where do we stand on advertising? Or on public service?
We wanna start on Wednesday.
Okay. Susan, what do y'all have, if y'all got a sheet that you can give to everybody so they can start using?
Checklist?
Checklists, yes.
We actually, Jerry?
Yeah, so we just first mapped out what this process would look like, pre-triage, triage, and then testing. This needs to be simplified into one checklist. This can be done by the end of the day, basically. But we need to check into what the testing capabilities are gonna be, because we would have put in the whole strep, flu, if negative, proceed, if
Well, just
positive,
assume
don't.
it-
So we just need to add that into that
Right.
decision-making.
I think there was a time, we're still kind of in that time where the COVID-19 test was the precious thing that we needed to be careful with. So if we could test for everything else, I would use 9 swabs if that's what it took to test for every other possible thing, and then send the COVID. We're moving into a time where the COVID testing will hopefully become more available, and the swabs are clearly less available. And so for certain people, the algorithm might be you jump straight to that COVID-19.
Sure.
And if that's negative, then you waste another swab testing for something else. I mean, that's just, the epidemiology is changing so quickly. Every test, how good a test is really depends on how much you expect to see in that community. And so when the levels are real low, the test isn't worth a whole lot. As it becomes widespread, then that test becomes more useful. And so at the point that most of our flu-like patients have COVID instead of flu, there's no sense in testing for flu first. Let's test for the high-yield thing first.
Well, I would agree. So it's just based on risk then. So we just have to determine what the risks are that would drive the test. So we have that mapped out here. We just need to put it on a one-pager.
Okay. And so you'll
We can
get
have that done by the end of the day or
You'll have
early
it by the
tomorrow.
end of the day and get it to John and get it to every testing facility. So you've got one, Baptist has one, St. Vincent's has one, get one to Kurt for the VA so he can.
So the other thing we talked about, and I want to get to how we're going to staff this, but the other one was, do we want to revisit having a central Little Rock location, just from a population standpoint? We would probably, from an Arkansas Children's Hospital, we can't send staff to 2 different locations and staff ours, so we're going to have to make that decision to, if we need staff from our location to help, we will do that. Do we want to consider having a central Little Rock location and the Southwest versus going all the way to North Metro, just to catch as many people as possible? And then it would make more sense for us to give up our location to a centralized.
I think our first priority is the Southwest Little Rock Hospital.
It's demand, that's the reason I was trying to figure out what the demand is that everybody had. You know, if you're having, John?
With the use of Southwest, do you anticipate ambulance traffic making deliveries there?
I think runs from there.
All right.
That'd be the only thing I'd really be worried about, somebody showing up.
John,
Sure.
if you've got someone in an ambulance, they need to be going to a hospital. They need to be going to the
I
diverted.
understand, that's why I'm asking, is there's no expectation that we're gonna be using Southwest as a destination?
No,
Okay.
the reason I want this list is that I want your driver to know that if they have these things on the list, they don't go to the hospital to have a screening, they go to the hospital and have someone really put their eyes on them and look at them. And that's the reason, the one thing that we have not figured out yet is, as it gets worse, how we know who's got capacity and who's got too much, who's got overburden.
We have a mechanism in place at MEMS to help do that. With the backbone on the trauma system. We can use and that's why, one of the reasons why Jeff is here, he's the manager for TraumaCom. And the hospitals already report to us status when it comes to trauma. So there is an opportunity there for us to keep up with available bed space.
Can you modify what you're doing to have that be in play, where we know capacity and we know availability? Yes, sir.
Yes, sir. Good morning, or afternoon. Jeff Tabor with TraumaCom. So we can do just that. So our dashboard currently does track all 15 different trauma-related capacity and capability issues, as well as the ICU and the ED for medical resources. There's also ventilator support within EM resource. There's over 800 data points that can be tracked in EM resource. So it's a user, it's an end user product where the hospitals update their information and keep it live, and that's how we make our recommendations based off capability and capacity.
So this is a great resource for us, and I'm all for using that. There's also the have bed.
Yes,
So whatever we want to, we got a couple different things going, so I'm great with picking one. Let's pick one and let's go.
Let's do that one. I mean, so you're in charge of it. When you pick up someone, or if we say there's someone in a hospital, then we can call y'all and say, Baptist has got 3 ventilators left and 4 patients that need to be on a ventilator. Where's capacity? You can do that.
Yes, sir.
Okay.
So let's coordinate, though, that we're not turning it into different folks, because right now we're doing, we're half bed every 12 hours, and so I know each hospital and every administrator may or may not know that, but they've got somebody in their organization that's sending that data in.
So what I would recommend is not changing that. We will use the have bed from the backdoor side. You keep entering as you're doing it, and we'll gather that information.
That's great. I didn't want to create a duplicate thing there, so
Yeah.
I'm all in. This is a great program, works really well.
So we can tell our ERs or our hospitals that if you've got if you've got people that need to be assessed for a ventilator or something like that, that we'll call y'all and you can say, the medical center has 3 ventilators left, ship them over there. And that means y'all have to be able to transport them too.
We do, yes, sir.
Okay, so you've got your people ready with everything protective wise to get them place to place. Is that right, Chef?
Chuck.
Anybody got any other things we need to bring up?
On the point of the trauma, just one point of clarification though, because we already have relationships with all the hospitals to report the trauma dashboard. So unless you give me guidance to the different, those are the same people we're gonna work with to incorporate this aspect of that.
That's fine.
Okay.
Is that okay with every hospital?
One point of clarification there are hospitals in here that are not on the trauma dashboard that we still have access to from the have bed system, like surgical and the heart. So we would still have there as for
Quick question regarding how are places planning for a surge in patients that have to be how are they going to be handled regarding regional distribution within your facility?
That's what I want them to be able to do. If they have people that we need to hospitalize, someone needs to be a clearinghouse that says, I know that you think going to the heart hospital would be a funny thing, but they've got capacity that everybody else doesn't have. That's what I want them to be doing. That they're the ones in charge of saying capacity for hospitalization and capacity for ventilators.
But what if we reach our capacity regarding hospital beds?
Then Frank is working right now on outfitting, hopefully, Southwest Hospital for hospital admissions if we have to do it.
Yeah, I would just throw in there too, we're starting the conversation at Arkansas Children's, something to think about maybe offline from this group, is if everybody gets saturated, we could raise our age limit and offload some of the healthier adults that are hospitalized in your systems for things that we could potentially manage so that you can manage the sicker individual with coronavirus. So that's something to consider. We're kind of working through what that list might look like, and then we'll get it out, what the age limit would be, what that list of diagnoses would be, and then we can kind of have that conversation potentially.
And this thing of resources is only good as the hospitals if they update them. If they don't update them,
Yeah.
you know, then it's worth nothing.
So-
So there's some onus on us to update them, so I think working well with John's team on that is gonna be important, because you get in the middle of something, you don't update it, it's worthless.
I thought it was, you said the other day that Washington Regional has a whole floor ready. I think we ought to be all looking to see a whole floor we can clear out and take care of patients.
I worry less about finding space than personnel to take care of the
Yeah.
patients. That really could be our limiting factor.
It's not gonna be kind of elective or essential, but really tied to a more concrete kind of timeline. Infectious disease physicians, what would, if it was today, making a decision, what would it be, 4 weeks, 6 weeks? Kind of the delay, because I know, I have a feeling that's what everybody's thinking in their minds, like, what is this gonna do? Financial ramifications for really tying all that off, and then that's really the thing.
Yeah, and if each state published their own little epidemiology curve of where they are and how fast they went, I mean, we know, I think 3 days ago, we were at the number that Italy was at 11 days ago. And now, of course, last I looked, it's like 25,000 in Italy. So, I mean, that's the nature of exponential growth. I think, again, the earlier you curb that process, and there's lots of evidence of this, I'm not making this up, there's like lots of evidence throughout history, when you put in these strict social distancing measures early in that curve, it is always gonna look like you're overreacting, because there's not that many cases yet, but, it's always gonna look like you're overreacting, but if that's the point where you make these changes, then you can actually, flatten the curve like we all keep talking about. And as long as the curve is pretty flat, then you have wiggle room to be talking about low-risk outpatient procedures and continuing to go on in some capacity. Once you're on the rise, even if you put in those measures right then, in a lot of ways, it's not that it's too late. I think we can always impact this. We can always make a difference. We can always make this better. So I don't want any sense of like futility or hopelessness to any of this. I think we absolutely have the power to change the course of history here. But the later you implement those changes, the higher the curve peaks and just the more damage that happens. I mean, the more healthcare workers that get exposed and then have to be quarantined or ill. And a lot of my personal motivation right now is just thinking about, we're very early in this curve, and I'm already dealing with, I don't have a number, but a lot of healthcare exposed people. Not just in our systems, but all of our systems intermingle, and our employees are married to employees at other hospitals and that sort of thing. And so there are already so many RNs that are quarantined for 14 days. I mean, our state on the whole, and maybe Laura Nervine could get us more accurate numbers, but already my workforce is stretched. And at these smaller hospitals, medical staff's down to half, already today. And so some of my urgency is every day that we're doing elective procedures, every day that we're bringing someone in to recheck their hemoglobin A1C, how many exposures is that? How many healthcare workers is that I'm going to have to quarantine for 14 days? What am I going to do when all my nurses have been exposed? And just in that equation is the PPE issue. Like, there's not enough masks to go around. There's not enough PPE to go around. Elective surgery burns a lot of masks. A lot, thousands a day that we're using in our state. That's one facility told me 1,200 surgical masks a day. And those aren't all elective. I mean, some of those will still get used. Surgery will still happen. But if we could stop burning those for a few days on things that could be postponed, that gives us a little bit more of a head start. So when I need those masks to protect my healthcare workers is really my concern, is that, you know, we did that so someone could, like, have their knee replacement. Like, I mean, that just seems so unethical to me, to still be doing those sorts of elective procedures when we really need to save this stuff. And save those patients. It's unnecessary exposure for the patient. Coming to a hospital in the middle of a pandemic, worst place you can be. It's unnecessary risk for the healthcare workers. Those OR nurses are being exposed to extra patients that they don't need to be exposed to. And then it's unnecessary use of our surgical mask and our PPE that I'm about to have to repurpose for all sorts of stuff. So, I don't even know what the question was, I'm sorry.
I was asking for weeks.
But it was a nice talk.
Seattle has, give or take a few, around 800 cases. And we all know, you know, you've kind of got in your head how long that's been going on. It's only been 2 weeks, but it seems forever, okay? So they're at 800 cases. They've got 42 deaths. They have not peaked yet. The governor just issued the same kind of thing that our governor has already done now, shutting down bars, restaurants, all that kind of stuff today. They're already out of personal protective device. Their epidemiologist from the University of Washington says that it may be 2 more months before they stop and see it all kind of level out and flatten out.
I think Seattle, 8% of the population is infected.
Yeah, and I was going to say, because they have huge community spread, well, let me rephrase that. They have huge community exposure. We don't really know what the denominator is. So to answer your question, it depends on how effective flattening the curve is and what our measures do. But if we are successful in mitigating the spread and able to be successful, we're still looking at 2 months. Give or take a couple of weeks.
Yeah, no, I think that's...
From a non-health system administrator perspective, what I think I heard Doc say over there is that while it's great to talk about what the health systems are doing to minimize exposure within their systems, which you should be doing, it sounds like there's almost a greater need for even more social distancing to be done across the city. And I wish the mayor was here to say this. I think we're tiptoeing around the fact that that's great to do it within the health system. It needs to be done to save personnel, but it needs to be done across a broader societal reach to further limit any further exposure. And that's maybe outside the scope of this, but I think that's what it sounds like.
It's not.
Anthony Fauci came out.
Yeah, can we let's clarify? I think Kendra would back up because Mayor Kendra, everybody's been looking at this with the city attorney. Even under emergency declaration, the mayor really only has the authority to institute a curfew, and that's what he announced today, starting at 12 a.m. Wednesday morning. Anything more than that really has to come from the Department of Health and the governor, and or the president.
That's fine, but the mayor and the city council the city board has the ability to ask for that if they think it's necessary.
But we are asking for it. Okay. And what's happening, Kathy Peck is on the city board and is extraordinarily conscientious. So she put out a thing today that starting tomorrow she's closing the restaurant to keep people out. And Susan won't have any place to eat, but that's okay.
That's a very socially responsible decision.
Right, and other people are starting to look at it. So hopefully we can get a momentum going in Little Rock. And, you know, there are lots of really good people around who want to help. And so you take the Kathy Pecks in the world and you start doing it. And as I said, we're going to stop doing procedures this week. I hope the other gastroenterologists in town will do the same thing. It's everybody's got to do their little bit. And as someone said to me today, you know, our fathers and grandfathers went to war and rationed and went through the whole thing for a whole world war, and What we're asking people to do is stay at home for 2 or 3 or 4 weeks. I mean, it's, you gotta keep this in perspective of what we're asking people to do. So, I agree with you completely. The biggest thing that the city board has to do, and we have to do, is start saying to people, don't go out. Don't do anything. Stay away from other people, because you slow that curve down, and if you slow the curve down, then we can take care of the people that get sick. And that's the whole key to the whole thing. And that's the message. And so we're all working on different ways of doing that and trying to be socially responsible. So
I think that we're, just about all of us are seeing some effect of social distancing on the number of people that are coming to our hospitals, coming to our clinics, and that's good. I think we all have some plan in mind to significantly reduce visitors, screen everybody at the door. If we don't, we all need to have that in place now. One question, though, Amanda, back to the people that we've got quarantined. If we cohort all of our persons under investigation or all of our positive cases to a single floor, if we have asymptomatic people that are self-quarantined, can we use them on those floors to continue to provide care if they're willing?
So, that's a good question. Certainly in other parts of the world that have been hit very hard, they've had to resort to that. It's not an option to leave asymptomatic people at home. We know that that increases the risk of ongoing transmission. It is certainly not ideal. I would hope that we were doing a better job on the prevention side. And it is possible to do a better job on the prevention side. I mean, there are parts of the world, Hong Kong and Taiwan, and in those places, healthcare workers aren't getting sick. But in other places, we see healthcare workers are the worst hit population, really. I mean, they're at the highest risk. And so there are measures to take now to prevent those infections to begin with. I think that is a much better scenario than letting a bunch of exposed, potentially contagious people work.
You know, one thing, this is going to sound basic until I saw it with my own eyes today. We've been talking about PPE, we've been talking about personal protection, and in one of our areas, witnessed a nurse with a mask down below her nose. And so we're telling all of our staff, you know, that we've got to police one another. If you see someone not practicing hand hygiene, not wearing their PPE appropriately, speak up. Because you're doing it for their benefit as well as your benefit, as well as the benefit of everybody else around.
Right, and think that the PPE seems so simple, like you just put it on, right, and then it personally protects you, but it's really not. I mean, it requires training and really like observation and so it's, we can't, it's not enough to just hand out masks.
Yeah, and so in all of our hospitals, we need to have a video available, and there are plenty out there to show co-workers how to appropriately don and doff, love that phrase, don and doff PPE, but also have graphics that are widely distributed in our nursing units about the right way to do it, because we just can't assume that everybody knows how to do it correctly.
let me ask one other question, then we'll get through for the day. It's Dr. Patel there. He was right there.
There he is.
There he is. Man, it's a question. What is our capacity now for testing, and how do you want us to prioritize what samples to send you to be done until we have more testing? And that's the real, I mean, of all the things that I know right now, if we had more testing, then the patient, the nurse that you got in quarantine, you could say you don't have it and then move on with life. So what's our capacity, and how do you want to proceed? How do you want us to prioritize specimens to send you?
So right now, I think we can do at the most about 40 tests in 2 batches, at least this week. Things may change at the end of the week based on the new testing dates and other things that may be whether through the public health lab or other now we might have up to 40. We might so 20. So we have, the way we are going according to our protocol is, we have about 20 cases or so. So the closest contacts who are symptomatic and need testing, we are testing them first. And then whenever we are getting calls from providers throughout the state, if there are cases that are meeting criteria, we accept those specimens also. So we are basically running this lab. We are receiving that many specimens.
So you're screening?
Yes. They call us and let us know we have nurses, and the nurses will take the information, give the physician information to us. We call them back, and if we all agree that this is they fill in the form and send us a sample.
Would it help you if each hospital had one person that we went through and know to talk to you or talk to y'all? Well, I'm just thinking there's.
I think for Baptist Health, we probably do, and it's probably me, and I sort of see that lab as my precious backup plan. So those are very high-risk patients, definite known contact with a COVID patient, and then high consequence. I can't just leave them at home. It's a cardiologist or something, I mean, it's almost always a healthcare worker who's had a lot of contact with a lot of other people, or needs to tomorrow have a lot of contact with a lot of people, where I really do need to know if this is just a sniffly nose or that sort of thing. And so that's really what we've reserved it to. Almost everyone else, either they're outpatient and they can self-quarantine, or they're inpatient and I can control the exposure. So I can put them on precautions and control that. It's either one of our healthcare workers that's already been around a lot of people, and I'm going to need to know if we got to start making phone calls, or that is just so essential that we need that information. So that's really almost the only ones we're sending to the health department.
Yeah, I'd say we have the same process in Arkansas Children's. That it would centralize through us, and we've been very restrictive over who we've actually tested, and it's mostly been healthcare workers versus patients.
The process currently is working. Everyone knows what to call, especially the St. Vincent Baptist, UMS, and Children's, the major area hospitals. The ID doctors know us and all that. They call, the infection control calls us. So we discuss, and if we both agree, we get the test immediately.
So they talk to you? Who do they talk to?
Yeah, they talk to me or one of my colleagues, so they all know.
So sometimes I just start calling until I get someone to answer.
I got someone on speed dial.
We expect by middle of next week to have capacity to do 400 tests a day, and with the turnaround no more than 8 hours.
That will make life a lot simpler.
We're going to start doing send-out testing probably tomorrow.
So Baptist is doing send-out testing. We're starting to see those results rolling back in from ViraCore. We've sent to Quest. I don't know that we've gotten any results from them, and then LabCorp.
But those are still 3 days.
It's pretty slow turnaround time.
So ViraCore offers a more expensive test for a 24-hour turnaround time. We'll see how that actually goes.
We haven't found that yet. We use ViraCore almost specifically.
They said the 24-hour turnaround time would start today.
But Stephen, if you're going to have capacity next week,
Right.
how do we access that?
Whoever needs a test, send us your sample.
And how do we prioritize?
Well, I think that the prioritization is on your end, and then we'll take our cue from you.
So
And we work with the Department of Health to make sure that.
right. So we're going to have, by hopefully this time next week, maybe.
Probably Wednesday, the 25th, we expect to have we have a in-house developed assay that should be ready by this weekend, but caution, I'll say Monday. And then a commercial machine, which is going to depend more on getting the reagents than it is the machine capacity by Wednesday.
So we need, in order to anticipate that capacity, what do we need to get you the samples?
If you have a sample, you order it and send it to us.
No. Do we need median? Do we need carriers? What do we need to get you that sample?
We'll make it clear to everybody.
Okay, so we're gonna meet again in a couple of days, just to know. So you'll have something that we can hand out to everybody else and say, this is what you do, so we're.
And that 400, just to clarify, from, like, that you're testing for flu, strep, and
No, for COVID-19.
by next Wednesday.
That is what we have told the governor we're gonna do, so.
You've now told,
We gotta do it.
unfortunately, you've now told the pressure on it, which is even worse.
We've been telling the same story.
Need to ask that if you can include us in that, because we have our own people at risk. So,
Yep.
Talking about our next meeting, is there a possibility we can discuss video conferencing instead of putting all of us in a room? That's something we might be able to make happen.
Chairman, if I may, Stephanie and I just kind of spoke on the side about making sure we set up an opportunity. We'll get with our IT team and others to make sure that we provide some conferencing, video conferencing if possible, but we'll keep you guys posted about that, but we definitely want to move to that format.
So we're gonna summarize and wrap up. It's getting close to 3 o'clock.
We've already done it.
Got it?
Yeah. 2 days, we'll do it again, okay?
If you saw the latest guideline from the president, is no more than 10 people.
No more than 10 people.
That's we're gonna figure out another way to do it. We got 2 days to do it. We'll figure out a time.
Is that Wednesday?